Hello, everyone. Today, we are bringing you the second episode of the NEATCast. I am Dr. Jyoti Mishra, and the NEATCast brings you mental health advances applicable to our daily lives. And today, I have the pleasure of speaking with Dr. Nicholas Jacobson, who is really an expert in AI and mental health research. And we will be discussing an exciting new study that was led by Dr. Jacobson's group that came out earlier this year in the New England Journal of Medicine AI. And it is a trial of a generative AI chatbot for mental health treatment. We're here today with Dr. Nick Jacobson, who is a dear friend and colleague and an expert in AI and mental health care research and translational studies in this domain. And we're discussing a paper that he recently led on an AI chatbot and a randomized controlled trial of this chatbot. That was really exciting work, Nick. And tell us, you've been working on this for a while, or this came out just more recently?
Yeah, so we've been working on this beginning about 6 years ago in 2019, and trying to use generative AI for mental health. And the life cycle of this is essentially we had some really early work that in this area where we tried a whole lot of things that seemed easy, and were massive failures early on. And then we figured out, we kind of learned some lessons from that, and moved on in ways that helped us adapt. We've had over 100 folks on my research team that have worked on this, over 100,000 human hours into this system, specifically on just really developing Therabot. And so, yeah, very heavily invested in this area. I've been doing it for a long time.
Yeah, and really the cutting edge of this work, I was reading some of this and I wanted you to tell the users about what is so sophisticated about Therabot relative to prior chatbots that have been out, like the Wobot and others. But yours is really developed with many hours of expertise. And can you tell us a little bit more about that?
Why is it different, or how is it
Mm-hmm.
different from other areas? So chatbots have been used in mental health for a long time, actually. So like a computer scientist worked on, this back to then going back to ELIZA in the 1960s. And yeah, so I think there's folks have been interested in this. Chatbots have been really integrated in mental health for the past 15 years, especially. So Wobot's a good example. So the vast majority of this work that's been done to date has been in what is called sometimes different things, structured or authored chatbots. So these are chatbots that before you engage with it, somebody has written out everything that the chatbot would ever say. And this is, I will say customer service has also loved these styles of things. So I'm sure, interacted with this, these types of conversational agents or chatbots that have a lot of routing. It's essentially a bunch of pre-written statements with routing options that will take you through different ways of navigating the system. And they work well in that they are scalable, easy to create, easy to disseminate, very low cost to create and disseminate. And they they have some like small to moderate effects in trying to treat mental health outcomes. So, they do work. They do work relative to like nothing kind of like a little bit. But they're, and when you think about population scales, that those kinds of things matter. So like I think it's a reasonable way of approaching things. Um, I have done work in that space too. So kind of like when I talk about that, I think that we've done work in designing these systems and evaluating these systems ourselves. Um, that work is fairly fundamentally limited though. And that the possibilities within chatbots, um, within structured chatbots, are really not going to map to what a real conversation looks like. When you say something and someone adjusts their responses and the path, and having that really curtailed in a dynamic way, it's not really possible to do that in any sophisticated way with structured or authored chatbots. And so generative AI is very different from that, in that it's nothing is written out ahead of time in terms of what the model will say. There's things that the model has learned from and that are written out ahead of time, but the exact way that it applies that knowledge is far more fluid. So in that way, I think it acts in a lot of ways that humans do. So ways that incorporates, it allows a lot of fluidity, can address comorbidity in much more sophisticated ways. So like other chatbots or digital interventions, probably like the most personalized they usually get are modular. And you've got a module for this or a module for that. And maybe you've developed something that's like co-occurring or something like that. So it's specific to a given population, and it's like really more integrated and fluid, but then it's often not like it's usually doing that one thing. So I think a lot of what we're focusing on within generative AI, that part of the technologies, that can really be problem focused and address comorbidity, and I think a potentially more meaningful way. So thinking about this with, for example, you think about comorbidity, it's not that somebody experiences, say, if they have social anxiety disorder and an alcohol use disorder, I don't experience that as just social anxiety and just alcohol use, where we think about these as separate problems, but they're often integrated meaningfully into somebody's life. So somebody may drink in social settings to try to reduce their anxiety and arousal that they're experiencing. So it's not one then the other, I think is probably the best solution for things, but actually thinking about integrating the context of it all. And so that's where generative AI really has a potential to have real impact in trying to actually make sure it's as fluid as and engaging as it's really, I think, humans can be.
So cool. Yeah. I was actually struck by, the last point you made about comorbidities and how a more fluid system can, generate more realistic conversations about complex conditions on the fly. And in your trial, you had just over 200 people participate, and your inclusion, that is, people who could take part, had either depression or anxiety or eating disorder. Now, that was a bit unusual in that you were including all of these different types of mental health conditions. And maybe that's stemming from some of the things you just described, that you were confident about the strengths of these complexities. Can you talk about that a little bit?
Yeah, when you're designing the system, because of the way that you're designing it, and because of how common comorbidity is, um, the system really needs to be ready to treat just about everything that would come in the door as a clinician. So like if you are coming in and you're trying to have a trial related to a topic area, all of the context of everything else is something that a human would absolutely integrate. Um, and thinking about the care, like providing care in that way, comorbidity is like very much going to come up in these conversations and very much needs to be addressed properly. And so we started with anxiety, depression, and eating disorders. In large part, those were like home base areas, but Therabot's already been trained on pretty much every common mental health problem and some rare ones too. But I think because of that, it's that's part of our trial design. Is in large part it's been designed to treat these different aspects simultaneously, and so we're developing it. We're kind of really designing it in a way that can do a lot of conditions at once, and so that's part of the trial design.
So interesting. So when I saw who participated in here, we saw that mostly they were middle-aged adults and potentially people who are comfortable with technology and people who are maybe interested and curious about talking to chatbots about their mental health states. And I was struck by how fast you recruited. You did this trial in 2024, I believe. In 2 months, you closed recruitment for more than 200 people. Now, tell me a little bit what this speaks to the participants and the need for this kind of technology out there.
This was among the easiest time we've ever had in recruitment. I think folks are, a lot of folks are, I guess, in the media will say, oh, of course there won't be people don't want this kind of thing. Sometimes this may be the perception. I think folks are really interested in this technology and really very willing to engage. It didn't take us a whole lot of time to recruit, in large part because I think people were pretty organically interested. So yeah, I think to me it really spoke to the need, and that the acceptability is probably pretty decently high in terms of thinking about systems like this.
Amazing. And your reach was national, so that's worth emphasizing that, because it's an app on the phone, you could get it out there throughout the US. So potentially even people from diverse low-income backgrounds could participate in here as well. And you designed a study that was a 4-week intervention period. And I read that you had 95% people engage pretty well, about 6 hours. Now, was that intentional? You said like 4 weeks would be good enough. Is that from based on the literature of how long chatbots are engaging, or
There
how
is
did you
literally
decide?
no barometer, no literature that exists in this area. So yeah, so when we were designing this, we were trying to design something. It's different from traditional care systems in that we were really wanting folks to engage with it daily. The in large part because that's also the other benefits of digital therapeutics generally is that they can actually be delivered in the context of daily life. So I think we're more likely to actually have habits that actually are sustained over time because of this interaction in large part. But and so yeah, when we're thinking about the trial design, like what exactly we want folks to do, like we didn't want folks to engage in ways that are like relying on the technology exclusively, wanted to be really designing it to be problem focused. We designed the intervention content to be delivered fairly quickly to move into actual intervention delivery. And so in a lot of like a lot of internal testing within the team, it just with how we designed the system, it seemed about right. Frankly, it was an educated guess, to some degree, a shot in the dark at the other side of things. What the exact dose should look like, we certainly don't know within the Therabot system or more generally. I think that those things are open questions. Is what we did optimal? I have no idea. I mean, it may have happened to have been, but it certainly may be that like other longer duration studies or could be more effective, or there are things like that too.
That's great. And your results were really good. You showed very significant improvements in all the conditions that you took in, including depression, anxiety, eating disorder. And in this case, you were comparing it against a control that was a waitlist control, that is
Yeah,
participants who weren't doing something else.
sure.
And so of course, that's the first benchmark, that you want to make sure that your study is feasible and people are adhering and engaged, and you showed terrific engagement. So congrats on that. And where do you see this go? Like in the next trial, are you planning to compare it with a more sophisticated control, and what might that be? Or where are you taking this next?
Yeah, it's a good question. I think there are multiple controls that I am really interested in the future. Probably the one that I'm actually most interested in, based on how the trial went, is actually comparing it a direct comparison against humans. Um, Now, what the control condition and the human condition looks like is actually very interestingly difficult as a trial design to actually operate around. The first thing when you're thinking about that type of trial design is whether you want it to be blinded to the participant to be blinded to it. In which case, it's actually if you introduce like that you want the exact same tech stack, it's really gonna, the only way to do this in a way that doesn't unblind it, because of how humans are not going to be always available, right? There's not, we're not going to get our trial therapists to be on call 24/7, literally just for any message somebody sends. Uh, so I think because of that, availability to respond and really with low latency is something that Therabot can do, right? So it can respond extremely quickly within when folks will interact with it. The downside of that within the a trial design setting is that means that creating a mask condition is really challenging. Now, one way to do this is you actually reduce one of the things that might be really effective about it, which is that it can actually interact quickly and respond quickly. So we could like kind of bring Therabot down because of the humans, right? Like kind of so that, but I hate to lose the potency of an intervention just because we're trying to adapt it to a human. So it's yeah, doing something in an unblinded trial where we are not, or we're sufficiently vague in a consent that they don't entirely know what the two conditions are is another thing that we're thinking about. And then of course they find out about what the intervention was designed for. Um, and so I don't know, we're thinking about different trial schema to try to make sure that it's really could work. Could work and trying to help us disentangle how this works. In some ways, you know, it's as an interesting a question if it's unblinded and it's more traditional care system style head-to-head comparison. I think
Yeah.
those are some things that we're interested in, but we're all also interested in on the other side of things, kind of like lower levels of control conditions related to digital shams or things like that. Though even that in this world actually is not trivial to design around this and something that's actually comparable.
Yeah, there's so much sophistication coming about. We just reviewed in the previous episode this Resilient app that was about cognitive behavioral therapy, and that's still very much text-based and reading chapters about, cognitive behavioral techniques, and still it was effective to some extent with a smaller effect size than you had. And so it really speaks a little bit to the fluid, engaging nature of the things that you're putting out here. And, I would not want your Therabot to be dumbed down to compare to a human, but maybe it can be a human plus Therabot trial in the future, like some kind of combination that doesn't burn out the human. Because
Sure.
I was looking at some of the results, and some people were interacting with your bot for hundreds of messages a week. Some person had like a very large number of messages.
Yeah.
So
Yeah.
obviously a human therapist is not going to
Yeah.
comply to that. So that's pretty incredible as well. And the scale at which you would need human therapists when you have a 200-person study, that's also incredible. And you achieved this within 2 months of recruitment and completed that within a couple months after that. So getting that many therapists is also pretty hard.
You're right. You're right there. For practical constraints would be challenging for sure.
Awesome. So let's talk a little bit about just technological and philosophical limitations about what do we think about chatbots in healthcare. We talked about all the great positives, and
Yeah. Yeah.
yeah, what do you see as things we should really consider as serious when we design these things? And
Yeah.
yeah.
Sure. I think one of the biggest things that I will say, like I alluded to this at the beginning, where I talked about the failures that we experienced early on. It took us a long time to design a system that was first effective, but then secondly safe. And so the the safety piece is really a considerable aspect of things that is unique to generative AI relative to other digital interventions. Is it's riskier. I think the upside is greater, like I alluded to, but the downside is also greater. So like when you think about this relative to other types of digital therapeutics in the past, these can act in ways that are directly harmful. And they do actually. If you look at every foundation model to date right now that is put out right now that folks are interacting with, they act in ways that are profoundly unsafe related to mental health when folks are using them. And like that it's not good. So I think in a lot of ways, there's a lot of folks that are kind of a lot of companies that are emerging into the space, and they are just using like prompt engineering to try to get their way, or RAG or something along those lines, where it's like really light touch approaches to try to get these models to act or behave in the ways that they want. And sometimes that works okay for a little bit until it doesn't. And there's a lot of ways that these things really don't work. We do a lot of systematic testing to try to kind of continually refine our systems. And so because we're doing that, we do a lot of evaluation of other systems and along the way. And yeah, they can act in ways that are really not only not helpful, but directly harmful.
Yeah, and in your case, I did read that there were a good guardrails put in place that if there were conditions where there was any kind of worsening of symptoms or anything else that was perceived, then you did have a line available for crisis care and help, and a human help could come in that
Yeah. And
situation.
and we reviewed every message to or sent from the bot and in near real time. So because of this, yeah, we really tried to take it pretty seriously about like doing and overseeing this. It's a new setting, and a lot of folks are kind of deploying things like this. We wanted to try to do that responsibly.
Yeah, that's great. I know your group does really great work in that area, and really doing responsible yet cutting edge research. Now, I'm just curious, the people who were part of this trial, do you think they kept using it after the formal study period? Have you looked at that at all?
We withdrew access, and
Oh,
part of the same reason that I just talked about. We hadn't looked at trial outcomes or anything right until the trial was over. And so in doing this, we had this huge responsibility during the trial. I did not, frankly, for the first half of the trial, get a lot of sleep because I was reading every message that sent to her from these things. And so yeah, and because of that, I wanted a heavy level of oversight and involved in this early evaluation while we were like really looking at and systematically looking at how effective and safe it was. And so, yeah, the next trial will have kind of different safeguards. Long term, I don't think this level of oversight will be needed as we kind of have data on its on continued safety and efficacy, kind of reduce levels of safeguards that'll be in place for the next trial that we plan. But model-based flags, for example, for us to evaluate that allows it to be in terms of offered for longer and sustained periods without completely overwhelming the research team at the same time.
right, right. Awesome. Well,
So
this is obviously great data to help you train future models for crisis care as well. So that's great. So Nick, please tell us any final takeaways you have for the listeners from this exciting work that you're doing. And yeah, we would love to keep hearing more new sophisticated science that's coming out of your team, which is really, again, cutting edge and highly responsible work. So.
thanks, Jay. I think in terms of big picture, like I think the results look really splashy and they look good. We certainly um, are very happy with how it went. But this is not one of those things that I think everybody that I know that I've talked about the work, like their first conclusion is, oh, I built something like this really myself. And I'm like, when I've seen the folks that have built things like this and we talk about it at any level of detail, it's always been something that I know doesn't work. And so in that way, like it looks really good at first pass until you actually start to continue, like really do thorough evaluation of the system. And so like I think there are other folks that will be entering this space that do this really diligently. We don't have any like I don't know, we're not going to be the only players in this space, but my hope is that folks actually act really take their time with this, do it well, and don't deploy systems that are going to harm people at scale, especially if they're going to advertise it this way. Most folks that are using generative AI for the mental health. They're already using it in large part going to be outside of these, like something that's actually marketed as a mental health based product. Folks are using these foundation models for this already, but my hope is also that the companies that are offering this have increased levels of responsibility in using and overseeing their platform in ways that are kind of responsible and judicious, and trying to actually improve the quality and the safety of what they're putting out there. But that's I hope that hopeful. Maybe I'm optimistic, but it's probably yeah, we'll see. I hope that as these teams continue to grow and the science matures, that folks kind of continue to try to do this well and responsibly.
Awesome. Well, thank you for your rigor and setting a benchmark for 100,000 hours of, expert work that went into developing the Therabot. And like you said, hopefully future work in here comes in with similar responsibility and sincerity, and less sleepless hours for the research team in the future.
Yeah, we could all hope for that.
Yes. Well, thank you for coming on and doing this conversation. And I'm sure people will be very intrigued by learning that they can get mental health care with AI chatbots now with great sophistication and success. Thank you, Nick.
Thanks, Jyoti.
You can all listen in to the NEATCast at these multiple locations, including YouTube, Spotify, and Apple Podcasts. And please follow and let us know if you'd like us to discuss a specific topic. And we look forward to keep bringing you new innovations in mental health care. Thank you.